Hi, I'm Nicole. I'm from the pharmacy team. I'm here to talk about patient Edward Watts. He's a 73-year-old male who has heparin-induced thrombocytopenia. He's been on heparin drip for 7 days, and 2 days ago his platelet count dropped greater than 50%, and his naters are greater than 20. He has necrosis on right upper extremity, possibly due to HIT. He has a 4 T-score of 8. His ELISA is positive, and SRA is pending. He only has a peripheral line right now, and his HAS blood score is 2. So per the CHEST guidelines, we recommend to discontinue all sources of heparin, including heparin drip and line flush immediately. We recommend placing a central line as the patient will need long-term IV access and antibiotics. We want to initiate argatroban 2 micrograms per kilogram per minute with a dose of 204 milligrams or micrograms per minute continuous IV infusion. Adjust dose until steady state APTT is 1.5 to 3 times initial value by titrating in increments of 0.5 micrograms per kilogram per minute, not to exceed 100 seconds. The dose should not exceed 10 micrograms per kilogram per minute. I want to discontinue the outpatient use of ibuprofen, and he can take acetaminophen for knee pain. We're going to want to monitor the APTT every 2 hours until the APTT is within 60 to 90 range for 2 consecutive APTT, and then we can decrease the monitoring frequency. We'll also want to monitor PT, INR, CMP, CBC, daily and monitor signs and symptoms of bleeding and thrombotic events every 2 hours. If the SRA comes back negative, we're going to want to discontinue the argatroban and consider other causes of thrombocytopenia and then may restart heparin. If the SRA comes back positive, we can continue the current plan and add heparin allergy to patient's chart. Once platelets have recovered to at least more than 150, we're going to initiate warfarin 5 milligrams, and we're going to co-administer the warfarin with argatroban, as argatroban can falsely elevate INR. Once warfarin has overlapped with argatroban for a minimum of 5 days with INR of greater than 4, we're going to hold the argatroban for 6 hours and draw INR and APTT. If that INR level comes back within 2 to 3, then we'll just continue the warfarin. If INR is less than 2, we'll increase warfarin dose and resume argatroban with target APTT to 60 to 90. And if INR is greater than 3, we're going to hold the warfarin or consider dose reduction, and we'll recheck the APTT and INR every 4 hours and restart warfarin titrated to maintain the goal INR of 2 to 3. For the patient's skin necrosis, debridement of the tissue is required. We're going to monitor closely for any signs of infection. We're going to want to check the wound daily for infection. If there are any signs of infection in the wound, despite giving levofloxacin for the patient's UTI, then we're going to add vancomycin, 1500 milligram IV loading dose, and then we're going to give 1500 milligram maintenance dose every 24 hours with a target trough of 10 to 15 milligrams per liter, and then we're going to pull a level 30 minutes prior to the 4th dose. So in addition to the monitoring I said before, we're going to want to monitor the patient's temperature every 4 to 6 hours and CMP and CBC daily. Also, we're going to want to monitor the albumin if we are giving the vancomycin. Also, we're going to discharge the patient on warfarin for a minimum of 3 months. In addition to the HIT, the patient has a symptomatic complicated urinary tract infection. He has a temperature of 38.1, dysuria, and urinary frequency. He has a white blood cell count of 21.8 and has gram-negative rods in his urine, and he is tachycardic. We're going to consult nephrology due to UTI in male patient and to evaluate any underlying urinary tract abnormality or obstruction. Per IDSA guideline, fluoroquinolones are primary recommendation for complicated UTI, so we're going to initiate levofloxacin, 750 milligrams IV every 48 hours for 5 days. We dose adjusted because the patient has a creatinine clearance of 39 milliliters per minute per the Cockcroft-Gault equation. Once we have cultures back, we'll adjust antibiotics for sensitivity results as appropriate, and we'll reculture the urine in 4 weeks after treatment to test for cure. We're going to want to monitor his PSA, urinalysis 1, signs and symptoms of infection, urine output daily, his temperature every 4 to 6 hours, CMP, CBC daily, and also monitor if the patient complains of any tendon pain, as this could be a side effect of the levofloxacin. Patient was diagnosed with a PE based on the following criteria. He has a Hampton hump in his left lower lobe. He's tachycardic with a D-dimer of 6.1, and his O2 saturation is 93. He was placed on heparin and to be transitioned to warfarin when he developed HIT. So our plan, since the heparin is DC'd for HIT, he is currently receiving argatroban, and at discharge we will give the patient warfarin for at least 3 months with a goal INR of 2 to 3. We'll want to monitor INR daily and signs and symptoms of bleeding while the patient is on the warfarin. Thank you for the consult. If you have any questions, please follow up.